Welcome to Module 5 of this series, an explainer dedicated to the definitive microsurgical management of vestibular schwannoma. If you've been following along, we've already covered diagnosis, surveillance, and radiosurgery. Today, we're stepping right into the operating theater.
I'm your host. In this explainer, brought to you by Australian Dizziness Clinics, we're taking a highly structured clinical decision-making arc and applying it straight to surgical intervention. The goal here is simple: break down the evidence-based framework that guides surgeons and clinicians when managing these complex tumors, making sure we all understand exactly why and how these high-stakes decisions are made. Today, we'll cover the indications for microsurgery, compare the three main surgical approaches, look closely at the near-total resection strategy, map out the postoperative monitoring protocol, and wrap up with some key clinical takeaways. Section 1. Indications for microsurgery. When is surgery the definitive choice? Let's start with the why. Microsurgery isn't just an option, it's the definitive, non-negotiable treatment for several specific clinical presentations. We're primarily looking at large recurrence grade 3 and 4 tumors. Once a tumor exceeds 3 centimeters and starts causing measurable brainstem compression, surgical decompression becomes absolutely mandatory to prevent severe neurological decline. Surgery is also the go-to for cystic variants. Because these tumors have unpredictable fluid dynamics and rapid volume expansion, they actually respond quite poorly to stereotactic radiosurgery. In fact, radiation can sometimes make the swelling worse. Now, what if a patient has already undergone SRS and it failed? Salvage microsurgery becomes the required next step, even though dissecting irradiated tissue planes is notoriously difficult. And lastly, if we're dealing with an NF2 patient who desperately needs an attempted hearing preservation in their better ear, tailored microsurgery is the indicated path. Section 2. Comparing the three approaches. Navigating the lateral skull base and posterior fossa. Once the clear need for surgery is established, the next critical step is selecting the safest anatomical corridor. This decision branches out based on three main criteria: the patient's preoperative audiometry, specifically looking at pure tone averages and word recognition scores to gauge hearing serviceability, the precise anatomy and size of the tumor, and, of course, the surgeon's specific expertise. It's a highly tailored navigational choice between the translabyrinthine, retrosigmoid, and middle fossa approaches. Let's break down the specific trade-offs for these three corridors. The translabyrinthine route is incredibly versatile for any size tumor and gives you the widest cerebral punting angle exposure. It's fantastic for early facial nerve identification, but the major catch is that it fundamentally sacrifices any residual hearing. On the flip side, the retrosigmoid approach, a suboccipital craniotomy, also handles any size and allows you to attempt hearing preservation. But it introduces distinct posterior fossa risks, a 5 to 15% chance of CSF leaks, and a pretty prominent 30 to 40% risk of severe chronic post-op headaches. Finally, the middle fossa approach offers the absolute best hearing preservation rates, up to 75%. However, it's strictly limited to small intracanalicular tumors under 15 millimeters because you're working in a technically demanding, tiny space that requires significant temporal lobe protraction. Regardless of which anatomical corridor is chosen, there is one universal rule. Continuous facial nerve electromyography, or EMG, is absolutely mandatory. This real-time monitoring guides the surgeon's dissection. A nerve that stimulates well at 0.05 milliamps near the brainstem at the end of the case is your strongest predictor of excellent facial function when the patient wakes up. In experienced, high-volume centers, anatomical preservation of the facial nerve now exceeds 95%, and that is largely thanks to the rigorous application of this technology. Section 3. Near-total resection strategy, prioritizing functional outcomes over gross resection. Now we get to a profound modern paradigm shift. Historically, the ultimate goal in the operating theater was gross total resection, or GTR, chasing every microscopic cell of the tumor to maximize oncological control, no matter the cost to neurovascular structures. But outcome data has completely reshaped this philosophy. We now know that a near-total resection, or NTR, which intentionally leaves a tiny 1 to 2 millimeter tumor cuff safely adhered to the facial nerve, yields dramatically superior facial preservation. Stripping that final layer often leads to devastating traction injuries. Crucially, NTR maintains equivalent long-term recurrence rates to GTR, provided that any measurable residual tumor is followed up with stereotactic radiosurgery. For large Koos III and IV tumors, this NTR plus SRS strategy is rapidly becoming the absolute gold standard to protect the patient's face while still achieving definitive tumor control. Section 4. Postoperative monitoring protocol. Grading, surveillance, and rehabilitation.
Exiting the operating room is just the beginning. Meticulous functional grading as what ultimately secures a patient's quality of life. The absolute standard for evaluating facial nerve outcomes is the House-Brackman scale, running from grade 1 for normal function to grade 6 for total paralysis. The specific timing here is vital. You want to assess the patient at exactly 48 hours post-op. This gives us the strongest predictive baseline data for long-term facial function, right before delayed edema kicks in. Even if a patient wakes up with a temporary weakness, functional preservation often improves significantly over the next 12 months as the nerve recovers. These functional assessments integrate into a highly structured post-op timeline. At 48 hours, you secure that immediate House-Brackman grading. Then, crucially, within the first 6 weeks, the patient must be referred for vestibular rehabilitation. You absolutely cannot afford to delay this. The central nervous system has a strict neuroplastic window, and early physical mobilization is vital. Finally, at the 12-month mark, the patient gets their first post-op gadolinium MRI to establish a new surveillance baseline. Focusing specifically on that 6-week referral, the vestibular rehabilitation pathway is tailored for acute unilateral deafferation. The brain is suddenly getting sensory input from only one inner ear, creating a massive sensory mismatch. To help the cerebellum recalibrate, rehab integrates progressive gaze stabilization exercises along with targeted habituation training. The ultimate target, robust central compensation, and a meaningful improvement of at least 18 points on the dizziness handicap inventory. Section 5, Key Clinical Takeaways. The decision-making framework summarized. Let's distill all of this into the highest yield clinical pearls for your practice. First, always prioritize the facial nerve with a near-total resection strategy. Leaving that microscopic cuff is infinitely safer than chasing a gross resection. Second, strictly map your surgical approach to the patient's specific hearing status, tumor size, and your own expertise. Third, continuous intraoperative EMG is mandatory, no exceptions. And finally, get that vestibular rehab referral in early, within the first 6 weeks, to jumpstart central compensation. Now, this precise decision tree works beautifully for sporadic unilateral tumors, but it leaves us with a high-stakes question. If our main goal is facial nerve preservation and functional recovery, how do we balance these surgical risks when a patient is facing aggressive bilateral disease? How does the presence of neurofibromatosis type 2 completely upend the standard algorithm when the looming threat is total bilateral deafness? That profound challenge is exactly what we tackle next. In our 6th and final explainer of this series, we cover the complex management of NF2, the genetics, bevacizumab therapy, vestibular rehabilitation, and quality of life outcomes. Thank you so much for joining us for this explainer. To explore more topics regarding dizziness, vertigo, and imbalance, and to access clinician materials, please visit AustralianDizzinessClinics.com. Don't forget to subscribe and rate this series. We'll see you in Module 6.